So, good afternoon, all. I'm presenting behalf of Medicine One, Brain on Fire. So, 72 years old female from Vellore presented with the complaints of one episode of generalized tonic-clonic seizure on 14/3/2024. History of presenting illness: sudden onset of generalized tonic-clonic seizure with the uprolling of eye, frothing from the mouth, and not associated with the bowel and bladder incontinence. It lasted for 10 to 20 seconds with the post-ictal confusion. Past history: the baseline patient able to walk with the support for 1 year with a mild cognitive decline, and she had no similar illness in the past. She's a known case of systemic hypertension for 2 years and not taking medication for 1 month. Personal history: no addiction. Diet is consumed mixed diet. So examination: pulse rate was 78 per minute, BP was 190 by 100 per mmHg, and respiratory was 20. Pallor was present, and there is no icterus, clubbing, lymphadenopathy, and pedal edema. JP is not elevated. And systemic examination: CVS S1 S2 had no murmur, and respiratory system bilateral normal vesicular burden had, and per abdomen there is no non-tender and no organomegaly. And CNS examination: patient was conscious and oriented to time, place, person, and another significant finding was noted during the CNS examination. So, patient presented with the seizure. The differential was metabolic cause and vascular cerebrovascular accident and space occupying lesion and hypertensive encephalopathy and autoimmune cause and CNS infection. The initial investigation was shows that patient hemoglobin was 7.9, and the MCV was 107. WBC was 5,200. The neutrophil lymphocytic predominance. GRBS was 188. Sodium was 137, and calcium, magnesium, and creatinine and LFT was normal. The ALK is mildly elevated, and TZ was 11, and folic acid was 1.5. So patient had a folic acid deficiency. Supplementation was started, and the echo was normal. CT brain shows that bilateral periventricular and frontoparietal deep white matters hypodensity, and MRI was age-related changes are present, and EEG was normal. With this, patient was restarted on antihypertensive and anti-epileptic medication. We discharged the patient with the diagnosis of hypertensive encephalopathy. So, because of the after starting antihypertensive, patient does not have a further episode of seizure, and patient completely normal. So we thought discharge the patient. So after 10 days, he presented with the one episode of loss of consciousness for 2 minutes and poor verbalization and no issue of seizure and urinary incontinence. That time pulse rate was 92, BP was 130 by 80, respiratory was 22, and temperature was 102, core body temperature was 103. The examination respiratory system bilateral diffuse crepitation was present. And CNS examination was GCS was 10 by 15, no localizing deficit. Mini mental status examination was 17 by 30, and differential diagnosis was considered at that time so septic or pneumonia related encephalopathy or heat stroke. So investigation counts were normal. So sodium was 117 and potassium was 6.1, serum osmolality was 257, and urine spot sodium was 76. Urine osmolality was 307, and TSS was 3.68. T4 FTC was normal, and ATM cortisol was normal. In chest X-ray, there is a bilateral infiltration present. So EEG was done, that by hemispheric slow wave was noted. So patient was treated with the antibiotic and the electrolyte correction done. In spite of the 72 hours of afebrile period and electrolyte correction, patient had a persistent altered sensorium. To summarize, 78-year-old presented with the symptom complex of persistent encephalopathy and seizure despite correction of the reversible factor with the background of cochlear decline for 1 year. So a differential diagnosis was considered. Second admission was neurosyphilis and neurodegenerative diseases and paraneoplastic and Creutzfeldt-Jakob disease and autoimmune disorder and steroid responsive encephalopathy with autoimmune thyroiditis and CNS vasculitis. For this differential, the investigation was done. CSF was counts was normal. CSF protein was mildly elevated 48, and CSF glucose was 70. CSF viral PCR was done negative, and serum autoimmune encephalitis panel was negative. So anti-thyroglobulin antibody was elevated, and anti-thyroid peroxidase antibody was elevated, and BBB is negative, and TBHA was negative. So I would like to briefly tell about the steroid responsive encephalopathy with autoimmune thyroiditis. It's a rare autoimmune disorder associated with the thyroiditis. It is described in 1966. The first case study was done by Lord Bryan on 1966. So pathophysiology is unknown. So the thing was the unknown. The features was there is a toxic effect of increased thyrotropin releasing hormone on CNS, or a direct antibody mediated damage to the neuron and immune complex mediated deposition. These are the pathophysiology was considered. And clinical type of there's it's also known as Hashimoto encephalopathy. And after that they changed the name into steroid responsive, because of there is no correlation between the only association is there, no causation of the elevation of the antibody and brain tissue. So there is two types. Type 1 was recurrent and type 2 was progressive. In type 1, as a benign and vasculitis features, the vascular background is there, and a transient ischemic attack, stroke-like incident, aphasia, and focal deficit, and psychoneurological manifestation and altered consciousness are present in the recurrent type. So type 2 was progressive and indolent course. In this patient are presented with the status epilepticus and disturbance in the consciousness and psychotic symptoms, and psychotic disorder like paranoid or visual hallucination, and increased Repentia syndrome. So symptom common in the both type was seizure, myoclonus, movement disorder, and cerebellar manifestation, dystokinesia, and tremor, and gait disorder, ataxia, and stupor and coma. So Hashimoto encephalopathy, there is a diagnostic criteria for Hashimoto encephalopathy. There is encephalopathy with seizure and myoclonus or hallucination or stroke-like episode, and may be present with the thyroid disease or normal thyroid parameters are normal, and the MRI scan was normal or non-specific abnormality, and serum thyroid antibody was present, and the absence of neuronal antibody in the serum, and the exclusion of an alternative cause of encephalopathy by differential diagnosis. For our patient, there is a presence of a thyroid serum thyroid antibody was present. The MRI was normal, and so the encephalopathy features like seizure and persistent dementia was present, and there is a absence of serum autoimmune encephalitis panel also negative. So other causes were negative for this patient. So this Hashimoto encephalopathy, rapidly progressive dementia with the extrapyramidal failure. In the studies, it is told that this is the autoimmune mechanism with the vasculitis and non-vasculitis mechanism. The delayed diagnosis of Hashimoto disease may result in the catastrophic irreversible encephalopathy in patient who presented with a potentially curable dementia. So treatment of choice was steroid. So methylprednisolone 1 gram IV for 5 days for pulse therapy, and followed by oral prednisolone. Or we can start with the oral steroid 1 mg per kg on daily. It was told that there is a 95 to 98% of patient after immunosuppressive therapy, the improvement and complete disappearance of the symptoms. In our patient, we started on injection methylprednisolone for 500 mg IV weekly for 6 weeks, and after that tapering to the 250 mg weekly for 6 weeks. So landing point, entity of steroid responsive encephalopathy with autoimmune thyroiditis, and went to suspect and approach to the encephalopathy. Thank you.
Thank you, Dr. Puthalaraj. Questions and comments from audience.
TSH was 3.6.
When seen in substantial and normal thyroid patient can also have this.
Thyroid was also there. In first admission, it was a 7.6. Second admission, it was a 3.6.
So only the diagnosis is steroid responses over months.
So
or not immediately.
We started there is a immediate response. Patient ambulated and started oral feeds also. They're planning for a discharge, and some study shows that there is a 5 days of a steroid course. Started, patient immediate improvement is there. So we started a weekly course. 2 to 3 weeks, there is improvement is there.
Two questions. But how was the patient when you discharged him the first time? Had he gotten better and then he got worse, or was he persisting?
Persistent decline was there.
After the first admission for seizures,
Sir.
when you discharged, was the patient completely normal or not?
Slowness of activity is present, sir. 1 year of
Slowness of activity. Sir.
So, this patient had some mild cognitive decline in the past 1 year. So, she had just that. She had presented seizure as a completely resolved, no worsening from baseline symptoms. Now she presented with an acute worsening of the symptoms. So, after the first seizure episode, she was back to the baseline.
Second thing, found in the literature review that you did, is fever a normal part of this disease? Because you said
The patient presented with fever the second time, right?
Sir.
Is
Yes,
that known to
in-
happen with autoimmune?
No, sir.
I mean, Hashimoto's encephalopathy?
No,
No. So, what is the explanation for that?
Patient chest X-ray was shows that bilateral infiltrates are present. So
Bilateral infiltrates cause the fever.
no, sir.
What is the diagnosis?
Pneumonia, sir.
Why?
Patient presented with a community acquired
The
pneumonia.
patient was unfortunate enough to have also a community acquired pneumonia along with the
Along with-
Hashimoto's. You think she might have aspirated?
Yes,
She had a sensorium of 10 by 15, no?
sir.
Isn't that a more
Uh,
holistic possibility? Did you consider the possibility of heat stroke, Dr. Adarsh is asking,
yes, there's a heat stroke.
for the second admission?
Second admission was heat stroke was differential was considered,
Okay.
but no other features of features of heat stroke is there. So,
Like,
um, so after cooling,
if even after cooling the temperature, the patient did not improve.
so it's not a core body temperature 103, sir. So not a 104 we consider.
It's not very high. Okay? I have 2-3 comments. One is for a patient with GCS of 10, I'm not sure how you were able to do an MMSE, or was it done at another time point? Okay. How did you think of Hashimoto's encephalopathy?
Thyroid antibody was positive.
Why did you send thyroid antibody?
There's a progressive progressive dementia.
My question is, I'll rephrase the question. Did you find that the thyroid antibodies are positive and then thought of the differential, or you thought of the differential and then sent the thyroid antibodies? Because TSH is, the thyroid function test is more or less normal.
So we thought of autoimmune thyroiditis and we sent the thyroid antibody.
So you thought that the clinical syndrome, one
So
of the
the
differential was a
progressive
steroid
dementia.
responsive encephalopathy.
So progressive dementia is one of the cause for.
One more comment. You said that the pathophysiology,
Yes, sir.
direct TSH thyrotropin mediated effect is there. I don't think that is true.
Yes,
More and more, I feel that we are thinking that this is a spectrum of autoimmune encephalitis, which is associated with antithyroid antibodies.
Yes.
So it's a antibody mediated disease.
So there is a theory of there.
Maybe in older literature, but newer literature will not have that. Thank you.